Decades of antihypertensive research have rightfully prioritized reducing stroke, heart failure, and all-cause mortality among older adults. Yet, hidden beneath the surface of these triumphs is a persistent blind spot: the neglect of cognitive health in trial design and analysis. While aging adults and their physicians increasingly recognize the devastating impact of cognitive impairment and dementia, most clinical trials guiding antihypertensive therapy have made cognition an afterthought, if it is considered at all. The majority of large, contemporary randomized controlled trials evaluating antihypertensive strategies in older populations focus on cardiovascular endpoints and all-cause mortality. Outcomes that matter most to older adults, preservation of memory, independence, and quality of life, are rarely measured as primary or even robust secondary endpoints. Cognitive testing, if performed, is often simplistic, sporadic, or insensitive to early decline. The SPRINT-MIND trial, for instance, included cognitive outcomes as pre-specified secondary endpoints and demonstrated some reduction in the incidence of mild cognitive impairment with intensive blood pressure control. However, even in SPRINT-MIND, cognitive outcomes were ultimately constrained by relatively short follow-up, fewer than expected dementia events, limited sensitivity of assessment tools, and exclusion of many frail or institutionalized individuals. Thus, despite this progress, key questions remain unanswered, especially in populations at highest risk. A striking recent example is the RETREAT Frail trial, presented at the 2025 European Society of Cardiology Congress. In this rigorously designed, multi-center randomized study, frail nursing home residents aged plus 80 years with well-controlled blood pressure underwent protocolized step-down of antihypertensive therapy. While researchers meticulously tracked mortality and adverse cardiovascular events, systematic assessment of cognitive function was absent. The chance to elucidate whether deprescribing affects dementia risk or cognitive trajectories, critical questions for this vulnerable group, was lost by neglect. Trials frequently exclude the frail, institutionalized, or cognitively impaired, the same subgroups at major risk for both cerebral hypoperfusion and accelerated cognitive decline. Uniform targets for blood pressure may not suit the heterogeneous high-risk elderly population, where aggressive lowering could harm as much as help. Physicians must extrapolate from cardiovascular data, applying clinical judgment and routinely flying blind when counseling patients about brain health. To end this era of heart over mind, future antihypertensive trials in the elderly must make cognitive endpoints co-primary or robustly secondary. Enroll those most at risk for cognitive decline, frail, cognitively impaired, or institutionalized elders. Use sensitive, longitudinal cognitive measures and adequate follow-up. Report on both the risks and benefits for brain and body alike. Build upon the advances of trials like SPRINT-MIND, yet deliberately address their lingering limitations to achieve definitive, generalizable answers. The evidence and priorities of the past have shaped a landscape where life is prolonged, yet the quality of that life, especially mental clarity and independence, may be sacrificed without notice. Incorporating meaningful cognitive outcomes into antihypertensive research is urgently needed, lest new therapies save the heart but lose the mind for our aging population. A balanced future requires that we learn from both the strides and the shortcomings of studies such as SPRINT-MIND, pushing research to meet the cognitive needs of those most vulnerable. It's time to end the era of heart over mind. Our aging population deserves treatments that preserve both life and the quality of that life.